Hello everybody. I want today to talk about a new topic in urology, which is very important and as well practical. We will highlight one of the most important points in a simple way, which is called emergency endourology. Emergency endourology, it means you are going to do emergency procedures by endourology. It means it is not opening, it is through the instruments which you can deal with in disease conditions that affect the genitourinary system, and specifically the urological one. On the top, we have obstructions. When we talk about really the obstructions, which is indications, is the most important point that we are going to mention. Acute ureteric obstructions is one of the most top emergency. If it is associated with the infection, whenever you have got an obstruction with infection or signs of infections, is a top emergency, and you should deal with it as early as possible. And you should have a background of the history, physical examination, and imaging that shows the number of the stones and the type of the stones and the side of the stones is very important, and the degree of obstruction that these stones has made in the tract, in the tract of pathway of the urine, So acute ureteric obstruction may be due to stone or may be due to blood clots, and rarely may be due to carcinoma. We have got, for colic, I would like to remind you about the causes of colic by 4C. C1 is the stone for calculus. The other C is for clot. The number C is for carcinoma. And number 4 is heavy crystalluria that may obstruct the urinary tract. So as in the GIT, you have causes of intramural, extramural. We have, in case of intramural, it means inside the ureteric lumen, stones or blood clot. Mural, the wall of the ureter, like neoplastic, urothelial carcinoma or tumors. Ureteric strictures. Extramural causes, it means something that outside the urinary tract, pressing on the urinary tract and causing obstruction, like pelvic tumors, retroperitoneal fibrosis, and even graviditis. If possible, as I mentioned, immediate ureteric stenting is a must after inadvertent ureteric perforation during the urological surgery. So sometimes during ureteric surgeries you may have these complications, so it's better to have, whenever you want to do any emergency, it's better. So it's another cause that if you injure the wall of the ureter, you don't put a stent, it will cause edema and then swelling of the ureter and will cause obstruction. So you should always, whenever you do a ureteric stenting and you do a ureteroscopy, it's better for stones especially or for anything, it's better you should have a stent during complications of your procedure. Typically, how you do these procedures. You take the patient to the operating room, OR. You do cystoscopy. You go inside the bladder by your instruments. You visualize the bladder. and you visualize the trigon, you identify ureteric orifices, and then you are going, sometimes you have to do a pyelograph, ascending or retrograde pyelography. It means you inject dye, contrast, through your instrument to outline the upper ureter tract, to all the ureter visualized, to see where exactly the obstruction is, and then you deal with it. And then after that, the procedures, you push a guide wire. It is a very small, soft guide wire that would go through, negotiate the ureteric orifice, and will go upward into the kidney. After you pushing the guide wire over the guide wire, you push your stent, and then by something which is called pusher, you push your stent until it will reach into the kidney, one end in the kidney, and the other one is in the bladder. And then you take out your guide wire and your pusher. By this method, you bypass any obstruction inside the ureteric tract, top from the pelvic junction down to the ureteric orifice in the bladder. These are the stent placement instruments required. This is the operating room. A double J is shown, and the cystoscope set. And sometimes you may need a URS. All this should be done in a well-equipped operating room, including C-arm. It means you should have a fluoroscope and ultrasound. This picture showing how illustration of JJ stent has been left or put in the left side from the renal pelvis, the one proximal loop, and the other. That's good. Why it's called JJ? Because each end is like a J shape of, and you should always assure a proper function of your double J and your proper positions. Whenever you put in a proper position, it coils upward in the renal pelvis and coil in the bladder. This reduces migration and you reduce erectile symptoms, as is shown in the X-ray as well. You know, stent, after putting a stent, just to remind you that the stent may cause flank discomfort, bladder discomfort, pain, desire to avoid incontinence due to irritation of the bladder by means of JJ, I have mentioned in the previous lectures. It may cause hematuria, or it may end sometimes by pulse, pyuria. And one of these complications is vesico-ureteral reflex. It means during voiding, the urine may reflex back to the kidneys, which I think I have mentioned this in the previous lecture. Complications: malposition, too short, too long, migration, urinary infection, sometimes inadequate level of obstructions, incrustations of the JJ, fracture of the JJ, as has been cleared in the previous lecture, ureteral erosions, even fistula, and forgotten. So many patients, they forget that they have got a JJ stent inside their kidney and inside their urinary tract. Now, if you look, the stent is in its optimal positions of the right kidney, and then on the left kidney you have got the stones. So this was the case bilateral stones. PCNL has been done on the right side, and JJ stent has been left. And after 1 to 2 months or 3, you'll deal with the left side as well. Now, this is a malposition. You know, the lower end of the stent has not reached in the bladder. It is just inside the ureter, the ureteric orifice. You see, it's not been coiled in the bladder. This one, too long JJ. See how it has been coiled lower down over a trigon, pressing on the trigon. This is one of the complications that always the patient comes to you and suffering from irritative symptoms due to JJ stent irritation. One of this is proximal stent. Sometimes you may perforate the pelvic caly system. Your stent will go outside the kidney. Sorry. This one, other one is subtle indication for malposition with stent distance to ureteral orifice after reposition. You see, you saw this malposition. The stent is not probably in the this is a stone. Stent distant to this is a stone, and the ureteric stent is away from the stone. It means there's a false passage here. Migrate upward, migrate downward. Distal migration, proximal migration. On the right side, coiled in the kidney. On the left side, migrate down and coil in the bladder. Another emergency is not uncommon with stents. Is urinary tract infection. And causes is stent placement and colonization around your stent or JJ stent. Urinary tract infection is another emergency, but you should deal with it. It will come to you with a flank pain if it's upper urinary tract, fever, rigor, and sometimes associated with lower urinary tract symptoms. These are the incrustations of the another one in the lower end. Incrustation. This is how it has been operated on. The stones, very big stones in the bladder, and the other one in the kidney, and around the stent, stones has been formed from the kidneys down to the bladder. Forgotten stent. One other complications is ureteral erosions or fistula. The stent may cause ureteral erosion during its stay inside the urinary tract. Usually this happens when there is X-ray therapy. When a patient comes to you suffering from, for example, ureteric strictures or ureteric obstruction by tumor, and then you put a stent, and after that the patient sent for radiotherapy, and this radiotherapy will cause necrosis or will cause radiation infection, and then it will end by necrosis and fistula formations. Or after that, when there is a necrosis and the vessel is near the stent and the vessel will adhere to each other, the ureter and the wall of the ureter and wall of the vessels. And then after radiation, it will cause ischemia, and there will be a fistula between the ureter and the vessels, or the the stent will erode the wall of when it go outside, it will erode the wall of the vessels, and it causes a fistula between the vessels and the ureter, which is presented by hematuria. Sometimes it can be massive if it is with a great vessels. Arteriogram or CT angiography will delineate the side and the cause and the degree of the fistula, which is as mentioned or shown in this figure. Another complication is stent fracture. You see one piece in the bladder and the other one in the kidney. Forgotten stent inside the bladder, and stone has been formed around it. The other one, the emergency, is clot retention. Emergency. So we have discussed that the obstruction in the upper urinary tract is an emergency which can be dealt with by endourology. It means you just go inside the bladder and then to the kidneys through the ureter, and then there is any obstruction you bypass on treat accordingly. It's one of the endourological procedures for obstructions, whether by stone or clot or by anything. So we come down to the bladder after operations or after trauma or tumor or anything inside the bladder. There is a hematuria. This hematuria is severe. That clot has been formed in the bladder. This clot is going to obstruct the bladder outlet. Why? It's very important. Whenever there is a clot, there will be irritation of the trigon. This irritation of the trigon will cause spasm of the bladder neck. Once there is spasm of the bladder neck, there will be obstruction to the outlet of this. And it was of the defending mechanism. When there is a retention, the patient starts to have pain, severe pain, unable to urinate, and there is clot coming out from the result. So the patient should come to the hospital because the acute retention of urine by clot or by anything is very painful. So hematuria or the clot retention in the renal bladder is a common health problem in surgical and non-surgical cases. It is an inevitable complication after transmural resection of the prostate or carcinoma of the bladder. Bladder clots lead to urinary retention and present as an emergency. Causes severe abdominal pain. It causes severe abdominal pain. And the patient, because of the pain, may have this blood pressure will rise, there will be tachycardia, painful over descent bladder. Rarely, we have got sometimes perforation of the bladder or rupture of the bladder through its fundus, the weakest part of the bladder. So prevention, how you prevent, whenever you have got, for example, an operation of the bladder, you should always, and you, for example, remove the prostate, you should put a 3-way catheter for irrigation. And then if you have done a TURBT, transurethral resection of the bladder tumor, a big one, and you guess that this bladder tumor is big and there is a lot of ooze and bleeding after your operations, after your resection of the bladder tumor. So it's better to have to left a 3-way catheter for irrigation to decrease or to prevent this clot formation. So when you face this case, this situation, put a 3-way catheter and start irrigation. If your irrigation is not satisfactory, you should evacuate. By what? Special type of syringe called Tommy syringe or Elix evacuator, which is shown in this figure. Sometimes the bleeding is so severe, there is a lot of clots which cannot be evacuated in this method. So you are going to take the patient to the operating theater and you do a cystoscopy and evacuate the blood, all the clot inside the bladder. You wash it and then you put the 3-way catheter and irrigate. If you see during this procedure, rapidly, if there is any bleeder point, you can cauterize it and stop the bleeding. This is how you go inside. This is the Elix evacuator and Tommy syringe. The other one, emergency. So this is an emergency. We have already mentioned this type of emergency of hematuria and how you deal with it. Sorry, in the previous lecture, just to remind you that these are done endourologically in the urological departments. The other one, third one, is urethral injuries, which is an emergency that can be dealt with by endourological procedures. Most urethral injuries are associated with well-defined events, major blunt trauma, penetrating, straddle injury, which is a type of injury that causes rupture of the urethra, iatrogenic injury to the urethra from traumatic catheter placement, transurethral procedures, or dilatation is not uncommon. So whenever there is a trauma to the urethra, whenever this trauma is iatrogenic, done by the doctors, or done by blunt or penetrating trauma, it's an emergency that the patient will have signs and symptoms of urethral injury, If it's a trauma, you have the patient triad of retention of urine, ecchymosis, unable to urinate. In case of penetrating, you see that there is a side of the penetration of the bullet or any sharp instruments. Iatrogenic, can be visualized during your procedures when you are getting checoscope, cystoscopy, or any other endourological procedure, not necessarily in the urinary tract and sometimes in the upper tract. Iatrogenic injury to the urethra from traumatic catheter placement. Sometimes inexperienced doctors or a nurse try to put a catheter and there will be a trauma to the urethra, or the patient will have got a catheter inside and you pull it, especially who have got Alzheimer's diseases or dementia. Just to remind you the anatomy of the urethra, you have got anterior and posterior urethra. Posterior urethra is prostatic urethra and membranous urethra, surrounded by external sphincter. And then you have got the anterior urethra, which is composed of bulbar urethra, and the penile urethra. Etiology, as I mentioned before, these are vehicle accident and sexual penile fracture sometimes associated with the urethral injury. Sometimes by patient pushing something inside those who have got psychiatric disease, they push foreign body inside the urethra. Penetrating, dog bite and animal bite. Sometimes we have seen amputation of the penis by animal bite. Constriction bands, paraplegia, they put a condom and then this condom is a plastic, but they will fix it by sometimes by plasters or by piece of ribbon, and it will cause pressure, necrosis, and bands around the penis. Endoscopic instruments, as I mentioned, and dilators or catheters. You should evaluate by means of retrograde urethroplasty the side and extent of the injury to the urethra, sometimes in experienced hand by ultrasonography if it's anterior urethra, CT scan, MRI in difficult cases, and the gold standard is you do a check scope to find out by means of flexible or rigid cystoscopy. This is the retrograde urethroplasty showing extravasation of the dye between the penile and the bulbar urethra. Partial tear, it is partial tear, you see, but still there is the pathway of the urethra can be seen, although there is extravasation of the dye around the urethra. Another examples of rupture of the urethra, the extravasation of the dye around the urethra. Partial one. And this one on the right side is complete without dye getting inside the bladder. On the left side, the dye can be seen inside the bladder cavity. So what are you going to do? You know, sometimes and it's very difficult to put a catheter inside. So what you do, you do a local incision, and then you are going to have a flexible cystoscope, identify a partial or complete urethral injury by means of this flexible, and you can do primary alignment with a urethral catheter. How you do this can be? You go inside by flexible, you visualize where is the trauma, you push a guide wire through your flexible, and then under the screen you see that the guide wire is inside the bladder. So you follow up your guide wire, you send stent inside, and after that you'll be sure that in the bladder, and especially when there is a partial one, you push over this guide wire urethral catheter, and then you take out the guide wire, and the catheter will be inside the bladder. So first you do a voiding cystoscopy or retrograde cystoscopy, and then it's better to do retrograde cystoscopy. And from above, you can do antegrade. Sometimes it's very difficult to go inside. You go from above and you go from down. By these two flexible, you can see each side of each other, and then they can negotiate the side of the trauma. Probably they're able to put a guide wire either from the bladder or from the urethra, and then over this guide wire you could place a small caliber catheter. So in flexible cystoscopy combined with RUG retrograde or voiding cystoscopy provide a more accurate and more immediate information of diagnosis. And somebody may say, how you do voiding cystoscopy? You can do puncture of the bladder, push it inside the bladder, and then tell the patient to void, and you can visualize the antegrade, the bladder, and the proximal part of the urethra. It's shown by cystoscopy how the complete obliteration on your left side, and then on the right side there is a guide wire inside, pushing, bypassing the stricture of the trauma side. This is a false passage. You see, they have been doing the dilatation without going through the normal urethral pathway, so there is I'm making a false passage below. There is two, so you can do two lumen, one above and one below. The one below is the false passage. And so that false passage, you go push a guide wire in the normal pathway, and then you are going to do dilatation over this, or after that you push a small caliber or small size polycatheter inside the bladder. Sometimes you may fail to do it. So at that time, what you do is just to lift a suprapubic catheter, and then after that you deal with the urethral stricture as has been explained by your teachers in previous lectures, especially on that of trauma to the urethra. And thank you very much.